When I'm not doing that, I'm running for my mental health. Okay, so this is, I think, my only presentation where I have not got something pre-prepared. So I'm going to ad-lib it, which doesn't normally end up well. Bear with me. But I think that a lot of my presentations, if you guys have heard me speak yesterday and the day before, a lot of the presentations just tie into one another anyway. Okay, so we've been experimenting with using electronic health records to strengthen retention in care at Manguzi Hospital specifically. And when I've spoken about data to many policymakers, many people at national and provincial, and even tried to lobby for computers in my department, it is very evident that people don't understand the complexity of rehab services. They are multidisciplinary in nature. So we're not going to have records that only speak to one profession. In rural areas, there's a very much a generalist scope. You are a jack of all trades. You are going to run multiple programs. We deal with very vulnerable high-risk populations that have multiple comorbidities, often require complex and very well-coordinated packages of care. There's an urgent need for active surveillance for selected programs. And by active surveillance, I mean, you need to check whether people are remaining in care, whether they are falling out of care. And if they fall out of care, you need to do something about it. You need to go and find them and find out why they fell out of care. Because if you don't, and you place the burden on the patient to reintroduce themselves to care, we are going to land up with secondary complications that are going to be very costly. They're going to be very disabling. And the very nature of our vulnerable high-risk populations means that they don't access care easily or readily. We have long-term clients, so continuity of care is really important. As I've said, they have complex needs. There's a lot of coordination across professions. And at most district hospitals, as well as, I'm going to say this, at tertiary hospitals, the structures are not in place for coordinating care between teams and between professions and between levels of care. Within a single client, you could have variable frequencies of follow-up. And by this, I mean, for example, a child with cerebral palsy, age 3, you might want to see them individually once a month. You might want to see them for a group once a month. You might want to have the parent facilitator see them twice a month at home for that. There's still intermediate seating, so that would be every 3 months you would want to check them up, but maybe in the first time that you've seated them, you might want to see them once a month for 3 months and then 3 months thereafter. They might need a follow-up visit with the doctor at the clinic for their chronic medication review once every 6 months. And by that time, your Excel spreadsheet is just insufficient and your head is just spinning. Okay. The status quo is that we really don't have a monitoring and evaluation culture within the Department of Health. There is no other way to say it. I cannot be euphemistic about it. It is awful. There is very limited understanding of data and data use in program and case management, both by undergraduates and by professionals, and it is something that we need to address really quickly if we want NHI to even remotely work. There are limited IT resources and support from DOH. It took me from 2015 until 2022 to get computers in my department. And the only reason I got that was because we got them from somewhere else. The reasons that I've been given is, why does therapy actually need computers? Yeah, I know. daily struggles. No? The existing electronic health records that I am aware of are largely designed around billing purposes, which is not something that we need. We need coordination and retention and care. The overwhelming approach is a passive surveillance. The onus is on the patient. If the patient cares enough about their own health, they will follow up. well, that is really not according to ICF, and we need to really recognize the significant barriers and the quality of care that is lacking that stop people from remaining in care. Our health systems are particularly weak, and our teams also struggle with resources. I don't have control over my HR. I have limited control over my budget. I don't have any control over my capital assets, to be really frank and honest. So it's a constant battle to get a car to go out. Every time we don't have a car on a day, it means that those patients that needed to be seen in that community then get lumped to the next visit, which then rapidly and very, very rapidly becomes unmanageable for a small team. Coordination is poor, as I've said, and then in my yesterday's presentation, I explained why that patient files always get lost, or you have an OPD file for OPD, you have a clinic file for clinics, you have home visit files for home visits, you have patient-held records, and then every time you get admitted, you get a different admission file. And if you belong to chronic care, you've got a separate chronic care file as well. So complete disaster, can't manage care. Disability and rehab data, we know that there are massive accessibility barriers, and the majority of our patients that are the most vulnerable remain hidden and remain unable to access care at all. You cannot use utilization data in isolation. There's no harmonization of disability, the definition of disability across the sectors. DSD, World Bank and Stats SA have recently embarked on a harmonization exercise. In 2021, there's a published report, Open Access. There hasn't been much, it's been a lackluster response between the different sectors, but it's a good start and we need to continue the discussion. The harmonization exercise is really that there's limited inclusion of disability status as an indicator across the various health programs and social sectors and education, etc. Rehab data is literally like how many sessions did physio, OT, speech and audio do? And then how many devices did you issue? It's not very helpful because you could issue the same device to the same people and look like you're doing well. You could be providing all your care in the hospital and we don't actually know what the gap is at all. So that data really doesn't say a lot to me. Definitely doesn't say anything to me as a manager of a program. There's no use of epidemiological data for denominators. There's not a lot of contextually relevant epi research either. And as a consequence, there's no monitoring of coverage rates, program performance, or attention to high-risk services beyond assisted device issuing rates, which really, those rely on the patient initiating the contact with the healthcare system. So it is those patients that have actually managed to access the service in the first place. And lastly, and it's probably the frustration of most of us that are in management, everyone wants a report due in 1 hour's time in a different format with data that you don't routinely collect. I've said this in my other presentations. COVID was very good to us. Lockdown was an absolute opportunity that knocked and threw itself in front of me. So we decided to revamp the service. We were lucky because we weren't swamped with COVID. So we pushed all our multiple databases together because we didn't have computers. We were, against POPI Act, holding them on our own personal laptops because that was the only way we could keep the databases going. But then when we pushed them together, we just found how many duplications and missed opportunities and poorly coordinated care and broken promises and everything else there was. We did a multidisciplinary prioritization exercise saying who we needed to see first and urgently so they wouldn't die or get admitted, and then went on from there. We made a purposeful decision to trace all of our lost to follow-ups that had moderate and severe disabilities as best we could. We then, after we'd done baseline needs assessments in the client's home for the various programs, we then kind of re-looked at how frequently we needed to see each patient and allocated a frequency of care to the various service attached to that patient. Frequencies of care are dynamic. They change with the patient's condition. and circumstances and rehab process. And that is something that is up to the individual clinician to keep changing on the record that we've developed. In the end, we had over 350 physical disabilities requiring active home follow-ups by the MDT, home visits with varying monthly consumables needed and different frequencies of care for the various programs that they were attached to on Excel. And we were just like, we can't do this. It's not going to work. And that was without adding the 1,200 mental health care patients that also needed managing onto the system. So the additional stumbling block was obviously the team. There was not a lot of appetite for admin. I don't know a single clinician that really enjoys admin. I definitely don't, but I'm forced to do it for most of my day. We didn't have a very strong team pulling in the same direction. Within professions and across professions, there wasn't great discipline. Clinical governance was definitely lacking. And in general, there was a bit of a revolving door approach. So like, oh, well, I'll just rock up at work and see what hits. And when they're out the door, I'll see them the next time. I'll worry about, did I order that assisted device? Did I do that? I'll worry about it the next time, or it won't be my problem because this patient's following up at clinic. It's the next person's problem. We had quite a lot of tech aversion within the team. Didn't have a lot of problem solvers. So it was the responsibility of a few champions to make a lot of changes. And as I said, we didn't have computers. So the rule with electronic tech stuff is that tech will not solve your problem. Okay. It'll help you solve your problem, but it will not solve the problem. 80% is team and 20% is tech. So we had to do a lot of teamwork first. Gillian sitting there was the mastermind behind all of these things. I'm not going to do this in detail because I did it in my previous presentation, but we initiated the 5 S's and the A3 problem solving approach. And the 3 things that irritated the team the most was a lack of discipline, monthly stats submissions that they felt the paper-based records took too much time and they were a pain. And there was they identified just within the wards, but a multidisciplinary coordination of care was not very strong. So we needed to address those. A3 was done. The only A3 that was done very successfully in the beginning was the discipline, which is still sustained. But I would like to say that the discipline affected the monthly stat submissions and the multidisciplinary coordination of care, but the electronic records also helped with 2 and 3. So I think that we have, in the end, addressed those. And we had to do a lot of puppy training, team challenges, role playing, and then the standing meeting as well, which held people accountable and got them sharing and got them discussing patients together. So lots and lots and lots of teamwork. So now our system is built around the individual patient record. So it uses a multidisciplinary clinical record for each client. It produces workload data. It can be an assisted device tracker. It provides clinical program performance feedback, and it is also an appointment scheduling system. So those are the 5 functions that our electronic system fulfills. The overall focus is retention and care and multidisciplinary coordination. So the workload data, it pulls the number of clinical entries, profession, service area, times, and units. So in the beginning, you go and enter, each patient has a patient profile. It's just got the basic demographics on, patient's clinic area, patient's age, patient's diagnosis, subdiagnosis, etc. And then every time you go and see a patient, or the patient comes to you, or whatever the thing is, you go into that patient's clinical profile, into their initial profile. Under that, you've then got a little tab for activities. If it's a general activity, that's where you go in and you just write your clinical notes in that activity. If it was an activity related to a specific special program, so such as the CP services, wheelchair services, assisted devices, there are tabs for that. You go in through the patient's profile, you go into that specific tab, and you write your clinical entry on that. The dashboard for workload data shows you at the end of the month, it just shows you how much per profession, how many sessions were done in what clinical area. And it also has a separate table which just spits out every single clinical entry that was logged that month. So you can actually go through and see. You can filter for a specific person. So as in that rehab worker, I want to see how many sessions that rehab worker did over in OPD versus in home visits or whatever. Or you can filter for the profession. So I want to just get physio stats. I can then go and see that. Or I can say, I only want to see stats from this month and this year, and it'll spit that out. Or I want to see how many patients were seen just at this specific clinic, Bigabuntu clinic, call that up. Bigabuntu clinic by physio, I can filter for all of that. So super useful for multiple reasons. The assisted devices, it tracks the assisted devices by category of device and by serial number. Not all assisted devices have a serial number. And I hope, Jean-Marie, that eventually we will be barcoding stuff so that we can just scan the stuff, and that would be great. Right now, we're not worrying about anything that doesn't already get delivered at my door without a serial number. That just gets logged as a device. It generates wait lists and tracks the turnaround time between assessment and issuing. It produces counts of devices that were issued, which is linked to the patient record. If you get a whole bunch of stock wheelchairs that are delivered, before you actually pack them in your storeroom, you simply log them on with your their serial numbers, sizes, whether they were donor-specific wheelchairs. So if Latter-day Saints delivers, we just link it to donor-related Latter-day Saints. And then at least when I have to generate reports for LDS, I know where all their wheelchairs are sitting. Hearing aids and wheelchairs and buggies have got separate tabs because we need more information for these devices. So for the seating services, I want to know what level of user is this, a basic, intermediate, advanced. I've even split basic into basic 1 and basic active. Basic 1 being all your gogos. I'm not going to call them every 6 months to have a maintenance and repair at their clinic because they take it for 1 hour a day and sit under the tree. They don't do a lot of damage to the chair. But my active users, I might actually want to follow them up every 3 months. So there are separate categories there. I want to know serial number. I want to know model of device. I want to know any accessories that I've issued because that has implications for when I run a seating clinic somewhere out in the bush. I need to know what sizes of seats and what type of breaks I'm bringing with and. But I also want to generate for budgeting purposes. I want to generate a list of things that I actually do need for repairs. And then there are filters for everything. You can sort for a specific type of device. So you want to know how many people are in WorldMate 3, so it's fine, we've got that. How many people are in wheelchairs at a clinic area. How many high-risk babies for their 3-month follow-up at a particular clinic. We can sort for that. Special programs, as I said, these are programs where if we don't actively monitor retention and care, the results could be potentially disastrous. So these are our special programs. Everything else, if you don't rock up for your back pain appointment follow-up, I actually don't care. I do care, but I'm not going to monitor you. I'm not going to go and phone you at home and ask you what happened. So the high-risk baby program, for those who don't know, that is an early screening and intervention program. Lara presented on the Sitalele one yesterday. We follow up our high-risk babies at their closest clinic every 3, 6, 9, and 12 months, after which they opt into a 5-year program or just get discharged. We have a early hearing detection and intervention program. All the hospital births get screened and then get followed up at clinic if necessary, if they fail the OAE. Then we have CP services, which require quite a lot of coordination and monitoring. Home visit services, we have both active home visits and then the more kind of maintenance home visit services. Wheelchair and seating services, hearing aids, assisted devices other than hearing aids and wheelchairs, And then groups, we simply put as a separate tab because it had separate sorting functions. These have all got separate tabs within the patient's profile. So if you're doing something related to this, you go straight into that. They collect, so you've still got a landing page for that special program as well that collects the extra information. Within that tab, you've got program performance dashboards telling you how well you're doing about retention and care. And then there's additional filters as well. So the clinic team pages, this I think is the crux around what has helped us as a department manage our teams. So we have, if you are a physio in my department, you have a set of between 3 and 5 clinics that are allocated to you for the year, along with the OT and the speech. And those are your clinics. And you need to manage everybody that is in those clinic catchment areas that needs your services, whether those patients need to be seen at clinic or whether those are home-based care patients or CP patients or wheelchair service patients or whatever. Those are your clinics. So what the app does is that it pulls data from the patient's individual landing, like their individual demographics page, and then as well from the special programs page, and any links from the activities. And then organizes all that data according to the clinic that that patient belongs to. So if you go into your clinic page, it produces an appointment scheduling list for that clinic day. So before you go, you can click onto your list of patients that have been booked for your clinic, and you can see in the notes whether they say, you know, take AAC board with, or like, remember to take a number 10 spanner, you know, or whatever you need to bring. It also produces a list of clients per special program attached to that clinic. So at least you know who's there in the community. And it gives you dashboards per program to indicate the kept and the missed appointments linked to the frequency of care. So for you'll have a wheelchair dashboard attached to that clinic, and it'll say you have got, you know, 30% of your users are advanced cases, 60% are intermediate, and the rest are basic 1 and 2s. Your follow-up rates for your wheelchair reviews are sitting at 40%. Like you need to back up. And if you go into that and then sort by intermediate, like by level of user, you can at least see, oh, we need Mareka here. That's going to be a problem. I can't do that myself. It looks also at the high-risk baby program. It can tell you what your fallout rate is, like your defaulter rate for the specific clinic. So we have run competitions between our teams. We call it Turn the Circle Blue. That means that all their appointments scheduled have been kept. And I can check the clinical notes to make sure no one's fibbing. And that team gets half a day off. It's amazing how quickly people want to turn that circle blue. Yeah, and yeah, it has made, I think I'm going to say this later in the presentation, but it has made handing over to new ComServes and new clinic teams so much easier, because you don't have that paranoia that services are going to get dropped and patients are going to fall through the cracks. So clinic teams may not possess all the necessary skills to address the complex package of care required. So they may not be advanced seaters. They definitely won't be peer supporters. If they're new ComServes, white, urban, upper class, they're definitely not going to be able to handle complex psychosocial cases that require community interventions. It is still the responsibility of that clinic team to then go to the person in the wider rehab team that has those skills and say, we need your help. When would be the best time to come with us to this clinic to see this patient or to run this specialized clinic, etc. And then, as I said, like there are dashboards tracking to kept appointments and give the team feedback on the appointments, and it makes handover a doddle. So what are the benefits as a manager? Well, multiple things. I just wrote down a few. I think I'm still learning, because the more random requests I get for data, or the more presentations I have to do, the more I have to go into the system and go like, oh, I wish it did this. And you're like, okay, cool, like put that on the list of like things to adapt. But the ability to extract data in the form of self-designed tables in order to organize outreach seating clinics. So if I'm going to Mboza, I need to know who is attached to Mboza clinic, including the satellite mobile points. I need to know what wheelchairs they're in, what sizes they are, what accessories they've got, what level of user they are, what their phone number is, and who their community health worker is, in order to start phoning them, in order to start booking them for that clinic, in order to know what spares to bring, in order to know how many people I need to come with me. Giving tracing lists of high-risk babies or wheelchairs for return to community health workers. Once a month they come to the hospital, we need to generate a list for that, of people who've missed their appointments. Getting waiting lists for devices for budgeting, planning, reporting, and tracking turnaround times. And just looking at assisted technology issuing and refurbishing rates, spares used, like that's all budgeting. And then just monitoring individual and team performances, as well as program performances. I can see where the problems are in the system. Facilitating case discussions, supporting juniors and coordinating care, especially if I'm doing program audits, I can look through everyone's clinical notes for once. They're not paper-based and sitting in someone's kaya. And I can see who has maybe missed the boat on something. I can account for stock finally. I can filter the data for various reports required by random stakeholders. We even introduced a client satisfaction survey onto the system. So my CVR worker does client satisfaction surveys and links them to the individual client record. There's a tab. I can just see how many of those were done. I can track devices for donor reporting purposes. I can do clinical record audits, and it can generate morbidity profiles if I want to sort by diagnosis. Has it helped? Yes, completely. The program data for CPN wheelchair services, because those are the ones that I've just audited, show significant improvements in access and retention in care from pre-electronic to current for coverage and follow-up rates. Between 2021 and 2022, so system running now since 2020, we initiated this system, late 2020, 2021, June, we started using it. I was like, I'm not accepting any more paper-based stuff. So June was the cutoff in 2021, and it's been running with increasing support since we got satellite Wi-Fi since then. And there's very little variation between 2021 and 2022, which for me says that we did a very nice handover with our ComServes, and the fact that nobody has really dropped out of care from community side. It has definitely helped strengthen interprofessional teamwork and reduced my stress levels and everyone else's stress levels in certain ways. In other ways, it has increased my stress levels, but it's for a good purpose. So yeah, is it scalable? Nope, not in its current form. The platform, the financing, the technical capacity to do so. Interoperability with existing and planned health systems must be a key consideration if we are going to scale this at all or pilot it elsewhere. But I think that the discussion should really be more about what is the minimum data that we need to collect, how we manage and use this data at the various levels, and for what reasons do we use this data. And that's the discussion we need to have, not, oh my gosh, there's an app. So just also of note is that there is definitely opportunity to build ICD-11 and ICF into the current format of how the thing is structured. But if you build too much in at one time, your team rejects it, and already admin is a so you're going to have to look at very good incentives. So like pay for performance or something before you're going to get that level of outcome measures willingly done consistently by rehab staff. And again, never forget the 80-20 rule. Are we preparing clinicians for NHI? And what is the incentive to collect, manage, and use this on a daily routine basis? Thank you.
Yeah, thank you very much. And I'm glad you are thinking of scaling it and making it accessible. So it's okay. So we'll take Steph and too many.
Okay, so
Just want
they
to
are,
see what first and Felix second. Thank you.
so actually Adele and Lauren basically had the same question, which was about rollout and where do we get it?
Okay, so at the moment, it is on a platform called NAC. NAC costs us 1,300 Rand a month for subscription purposes. It is linked to the amount of records that the app holds. So the more records you have on your app, the more you pay per month. We didn't realize how rapidly we would increase in number of records. We're already over 50,000. So although on this platform, you can definitely copy the app. If I had to copy it under my subscription, I wouldn't have enough records to allow somebody else to use a similar app. If I copied it onto your separate subscription, you would have to find money to pay a monthly subscription in order to run it. So that's the only way to duplicate it in its current format, which is why I say it's not scalable right now. And which is why I'm saying that we need to generate enough support and demand from clinicians, like end users like us, for something like this to be built that is interoperable with what is coming for NHI, but that is also scalable. And to do that, you are going to need actuaries, you're going to need tech guys, you're going to need M&E specialists. It's the little thing that Marika and Kate built. It's not going to scale. Yeah.
Thanks so much, Marika. Very inspiring. And I've got lots of questions, but I see I won't have a chance to answer them all. I think your last kind of 2 sentences about some of your questions answered some of my questions. My concern is that when I travel around to different hospitals, we don't really have therapists overseeing the different hospitals. I just see such varied practice at different facilities. And my question really to the rehab group is there, and maybe to Jean-Marie, my feeling is we need to standardize the quality of service that's being done at different facilities. I so often arrive in the therapy department and I see everyone sort of sitting around, having a cup of tea. And it just seems as if the practice that is happening in X place is not being practiced elsewhere. And it seems to me as if there's no real, from a national point of view, real understanding of what therapy does and how it ties in and what should be happening. And so you get a little therapist who goes to a hospital and they sit there and they kind of do their little thing, but there's not that vision of expanding it. And I think what goes along with that is the issue of vehicles. It seems as if in our province, the feeling is that you plonk a whole bunch of therapists together in a facility and there's no understanding about computers. We have the same issue, facilities, storage. They think that you need 3 rooms because you've got 3 therapists, but there's nothing about wheelchairs, maintenance. I actually found that if I need a screwdriver, I don't go into the maintenance department. I go to the OT and physio department because you'll find the most amazing, well-kept.
I've gifted Alan keys to our maintenance department.
So now I just go straight there. And they also know when you say I need a size 10, they know exactly what you mean. Whereas the maintenance guys, they look at you a bit blank sometimes. And then I just also wondered, it seems to me that a lot of our therapists who are working in these facilities, they don't have a good understanding about how to repair wheelchairs, how to prevent the thing from falling off, and then it's useless. And I wondered if there's something in undergrad training or so when I go to some facilities, they're managing to eke out life of some of these ancient pieces of equipment. And in other facilities, they're just accumulating at the back of the hospital.
Okay, so multiple things there. The car story is real even for us. I started an email in 2014 complaining about our car that was unroadworthy. And in June 2022, we got our new car. It was a string of emails like this, but eventually it got to the right person. And I mean, that's the frustration with the Department of Health. It's like, there are good people there, but it's to get your email onto the desk or read by the person that will do something is really difficult. And because it's such a bureaucratic process, you're never guaranteed. And my message to all of you guys is just keep the same email, keep the same thread, just keep persisting. Wheelchair services, I think that is what LDS is trying to initiate across the provinces, is an understanding that it's not just here's your wheelchair and cheers and like, you know, I'll never follow you up or whatever. I think that they have got a good vision, and I think that, well, they've definitely got cash and they're going around it with an MOU, which is good. Also, Scheffler has really been lobbying for ages as well. Like, and then there are like wheelchair group, like Eastern Cape's got a really cool wheelchair. Well, you can talk about it. You can talk about it. But I think certain provinces are a little bit more progressed and others not with regards to wheelchairs. The Rachel Swart Fund is also quite interested in training up, like proper training for repairers as well, and getting repairs going. Repairing takes time. And when I have to do it, I have a lot of my skills. I love repairing wheelchairs. That is my happiest place, is to just shut the door, put on some jazz and just repair everything. But my skills are better used elsewhere, to be honest. So KZN Department of Health has got a service level agreement with DPSA, and they've also tapped into EPWP program, and people with disabilities are employed as wheelchair repairers at each facility, which then frees up the time for therapists to do other things. But in order for that to work, you can't have a divide between therapy staff who say, oh, but it's the wheelchair repairers problem, and then just sits back, because it is a partnership and you need to be heavily invested and involved in it. So yeah, a bit of two to tango. I think there are lots of things about rehab that we need to take a stick out of our own eye, and we need to be having hard conversations from student level all the way up to try and get more standardization of practice. Building an app that has all of those things in place, well, as I said, like, it helped me to orientate my new ComServes as to what their function was. They wouldn't have naturally gone out to a clinic and finished the clinic at 2 o'clock and said, oh, let's go and do home visits. But the thing is, now you've got this circle that is green because you haven't done your home visits. So then you get back at 6, which means you get overtime, which means you can use it later as well. But it also means you turn your circle blue. So yeah, it's a tool. It's a good start for a discussion. Yeah.
Thank you very much, Marika.